In today's episode, we're going over a case study of a traumatic meniscus tear. Let's get going. First and foremost, thank you so much for your support. You truly allow me to do what I love for a living. My name is Dan Pope. I'm a physical therapist, coach, a personal trainer, and I am a meathead. This is the Fitness Pain Free Show, where we help coaches and physical therapists like you get your patients out of pain and back to training. If you're watching on YouTube, please hit that like button, give me a comment, and subscribe to the channel. If you're listening via podcast, please give me a positive rating and review. It helps me a ton. If you want to go that extra step and support the channel further, support me further, consider subscribing to Fitness Pain Free Insiders. It's a comprehensive educational resource and toolkit for the fitness and rehab professionals. Think Netflix, but for trainers and physical therapists. A lot of folks who watch my content will ask, how can I continue learning from you? I want to try to figure out your system. Well, this is like a no-brainer first step in order to do that. All right. So Insiders is kind of like Netflix, but for trainers and physical therapists. It's premium content all from me. I've been updating this monthly for the past 5 or so years. It's not really a hodgepodge of webinars. It really is a comprehensive continuing education program, all right? About as cheap as you can get. It's got over 100 webinars, ebooks, and complete guides. You'll have access to a private Facebook group to ask any questions. I'll answer them. You can decide upcoming podcast topics. Best of all, it's only $1 to get started for a week trial. After that, it's just $12.99 per month, and you can cancel it at any time. Now, I'll put a link in the show notes where you guys can check this out. Otherwise, all you need to do is go to fitnesspainfree.com, click on the programs link, and then click on Fitness Pain Free Insiders Online Library to get started. So our case study today is in a traumatic meniscus tear. And we're going to start off with the evaluation, and then we're going to progress along like you would see in a physical therapy SOAP note. So basically your objective, assessment, and then your plan of care as well as treatment. All right. So we're dealing with a 28-year-old male. This is an older patient of mine. I've actually worked with him a few times for a variety of different pain problems. He's a weightlifter. He's also a runner. He likes hockey. He's also a firefighter professionally. And on the side, he does tiling. So obviously a very fit and active person. And the other thing that's interesting for him is that his work is going to require fitness, right? And the other piece, and this is a little unfortunate given the injury they have, is that he has to be able to kneel. So if you're laying tile, you're doing kneeling for long periods of time. And after you have a meniscus tear, it's obviously pretty tough to kneel, right? So it's one of the things we had to focus on over the course of time. So he had a traumatic meniscus tear. You can tear your meniscus traumatically, or can it be more of a degenerative tear that occurs over the course of time? For him, it was all at once. So he was crawling in his job, firefighting, and he felt a pop with pain. He had swelling afterwards and had some limited range of motion. He actually did go and get some imaging. I was not the first person he ended up seeing. He saw a physician first, and then he ended up going to another physical therapy place first and came to us afterwards. And the imaging confirmed a medial, so inside of the joint, bucket handle tear. And I actually didn't know this initially. So when patient first came in, he told me he had a meniscus tear, and he didn't really know which type of tear it was, which is actually quite common. It's pretty common for folks not to know what the heck is going on, specifically within their joints or with whatever injury, right? So we're talking about the knee here, but oftentimes people won't know exactly what's going on with the imaging. So that's one of the things I pressed on the patient later, and we'll talk about why that's important to know in our decision-making process over the course of time, right? So what kind of stuff hurts? So for this patient, a lot of stuff hurt initially. And that was walking, standing, squatting, lunging, kneeling, bending, and straightening, right? So everything kind of hurt the knee. And I'll tell you what, this is really depressing for a very active person because it's going to affect everything in their life. So not just their training, which is something that is typically something that people do to get rid of stress in their life, right? To add value to their life. And you're taking away that coping strategy, right? And the other part is that it's going to interfere with his ability to work well. And that stinks because pretty much everything in his life is affected at this point. His lifestyle, his work, his training. So suffice to say, he's very depressed at this point. So what about this patient do I know and I'm getting from the subjective evaluation that I think is important for his future progression from a physical therapy perspective? So for one, he's a very motivated person. I've worked with this person in the past, so I kind of know this firsthand. So he's going to be very compliant. Like I said before, I've worked with him past injuries, and he's done a great job of just following through on everything that I've told him to do. Okay. The other thing that's kind of nice about this is that rehab for him is very, very high priority, right? So he actually had to stop doing his part-time tiling work on the side because he simply can't kneel whatsoever. And he's definitely struggling with his job as a firefighter. All right, excuse me. And here's the thing. So his sense of self-worth is wrapped up in his career as a firefighter, as it should be. I think it's great that people care about their career, right? And he's doing something that's obviously adding to my life, right? So if I have a fire, I want him busting through the door. I want him to be able to save me, right? And that requires a meniscus that works well. Also, he has to be able to exercise for part of his career, and he loves to exercise too. So a major injury like this really sets someone back psychologically because it's a major knock on their sense of self-worth, right? So because of this, the priority is pretty high to get out of pain and back to exercise and back to his job, right? So the other thing that was important about this patient is that he actually went to another physical therapist for a few months prior to seeing me, right? And oftentimes this happens just because we're out of network providers. We're a little bit more expensive, right? So because of that, early stage PT is sometimes handled by other people, right? And in this early stage PT, they just worked on the basics as they should. So restoring range of motion, working on swelling, getting that quad back a little bit. But the patient just didn't feel like they were making that much progress. They also didn't feel like the physical therapist really understood what the patient was trying to get back to. And it was one of those typical stories where you're going to a sports medicine clinic. I'm using quotations here because they call themselves, a lot of these clinics will call themselves a sports medicine clinic, but 80% of their clientele is geriatric. So if you get a young, fit person that's going to physical therapy at one of these clinics, they just don't feel like they, are supposed to be there. If you come to a clinic like ours, especially if you're an older individual, you might actually feel like you're in the wrong place too, just because we see so many young adults, so many young athletes. So when someone comes to a clinic like ours, it's the opposite experience, right? So that was one of the major reasons why they wanted to come see me. And the other piece is that they just wanted a boost. They knew that I was going to kick their butt and I would understand what they're trying to get back to. So they wanted that next step, right? So what were the goals that the patient had? And also what were the goals that I had, right, for that patient? I love to ask my patients, every single one of them, what are their goals? So we make sure that we're moving in the right direction over the course of time, right? So he wanted to prepare for surgery. And we'll talk about this a little bit later. But when he saw his physician, the physician did recommend surgery because it was a meniscus tear that could be repaired, right? Also, the patient wanted to be normal at work. He wants to be able to do his job responsibilities, get on with life, right? He wants to also make sure he doesn't hurt with all of his basic daily life, right? I mean, he's a tough guy. He's one of those folks that copes fairly well, but it hurts every time he tries to stand up. It hurts to straighten out his leg. He can't stand for prolonged periods or walk. Life is really limited right now. And last piece, and this is a little far off at this point, but it's always something that's on the top of my mind because I often feel that if we can get people back to some of the things they love doing, so like running, weight training, going to the gym, right? Then that's a major win psychologically and also from a physical therapy perspective for a patient. So he wanted to get back to hockey, running, and weight training, right? But that was kind of far off in his mind. He felt like, wow, that's, if I can get back to feeling better, that's a major win. But long term, I'd love to be able to get back to things I love doing. And then in my mind, I'm like, let's get back to these as soon as we possibly can while respecting that meniscus injury, because that's going to be a major psychological win. So done with the subjective portion. Next part of the evaluation is objective. What are we finding from an objective standpoint? From a strength perspective and manual muscle test perspective, he had pretty good strength in all areas besides knee extension, right? Now, I didn't check this. We do objectively measure strength later on in the evaluation. I didn't do it today. I just figured that it felt weak, probably was weak. I wasn't going to gain anything extra by getting an objective measurement with a handheld dynamometer at this point, right? Although that's probably something that would be smart to do if I had the extra time, right? In terms of range of motion, so always want to check the range of motion at the knee. That's going to rule in potential meniscus pathology, but B, it's also going to be one of those things that you want to check and make sure you're progressing over the course of time. So he had pain with end range flexion, very common with meniscus pathology. It was about 20% limited. He also had pain at end range extension, which is about 10% limited as well. Pain at end range extension is very important to note, and it's also very important to tackle early on because from a function standpoint, so think about standing, walking, all of those things require end range extension, right? So if you're limited there, then a lot of stuff is going to be painful and limited within your life. And it's going to make you compensate a lot and end up with other problems at other joints, most likely, right? So another thing you want to look for with meniscus pathology is there any swelling present? And yes, there was. There is some minimal swelling above the kneecaps, some on the medial side of the joint, right? Over the course of time, patient said that this was actually getting better, right? Which is great. The other thing you'll often notice in knee injury patients, especially those with swelling or after some sort of traumatic injury, is that they have a deficit in their ability to make a quad muscle. So basically, I'm just having the patient lay on their back, straighten their leg, go ahead and try to make a nice strong quad muscle on both sides. I poke around on the quad and I just get an idea of how well they're able to make that quad fire. Now, his quad wasn't too bad. And some folks, their quads feel like a bowl of mashed potatoes, right? It's terrible. You'll definitely feel this after a lot of knee surgeries as well. His wasn't too bad. I would say he had a minimal quad contraction deficit. That was probably worse in the weeks before this, though. From a regional interdependence standpoint, so we check the joints above and below to see if there's anything that may be relevant for their physical therapy rehab or injury prevention in the future. He's generally pretty mobile. So he's got decent ankle mobility. When he goes into a squat, normally he can hit full range, no problem. Great ankle dorsiflexion. If we look upstream at the hip, he's a little bit limited in hip internal rotation. This may or may not be something that affects his rehab over the course of time. We actually didn't address it too much because he was able to get back to most of his activities without trying to focus on hip rotation too much. But maybe for your athletes, if they're trying to get back to some sort of rotation, that would be a major consideration. What else do we see from an objective perspective? So for one, I just eyeballed this, but you can very easily take measurements. He had some muscle loss, looks like in the quad. I would say it was minimal at this point. So it wasn't a ton, but it's been 2 months since injury. So you can kind of guess that that muscle would be a bit weaker if A, you can't make it fire, and B, it hurts to do anything. You'll notice that muscle will get smaller over the course of time. I like to check a straight leg raise as well. So have the patient lay on their back, keep the leg as straight as possible, flex the quad, and lift the leg up, right? What we're looking for is whether or not there's a quad leg, right? So if I start to lift up and my knee immediately starts to bend, that's known as a quad leg. I like to note how much they have. He started with a 10-degree quad leg. Great. We want to try to make that better over the course of time. From a gait perspective, when you watched him walk, what were we noticing? So A, we're just picking up immediately on that limitation with knee extension. So when he takes a step, he does not straighten his leg out before heel strike. You see that knee bending, and you also see the knee staying bent during stance phase. So when he takes a step, he actually looks a little bit shorter on that painful side, right? When I ask him to squat, what do we find? So A, he has limited depth. It really just hurts to load up the squat. The deeper you go, the more it hurts, right? And the other part is that you notice a pretty severe initially weight shift. Now, we actually have force plates. We use VALD, V-A-L-D, force plates to look at someone's squat. We can get some feedback about how much weight they put on their left leg versus the right leg. He was definitely limited to begin with. We noticed the same with his lunge. Lunge was painful, right? So pain is going to change the way you move, obviously. He shifted towards his non-involved side, right? And the other thing that was going on with this individual is that they were starting to get some patellofemoral symptoms, so some knee pain on the opposite side leg. This is probably because of all the compensation over the course of time, right? So he was banged up, he was hurting, and he was depressed, right? We did a step down test next, and what you noticed that he just really used a big hip strategy. So when he stood on one leg and tapped his heel like he's going down the stairs, he just had a ton of hip drop. He just didn't want to move through that knee. Obviously, the knee is painful. The quad is getting weaker. He probably doesn't want to move through the knee joint. He's moving more through the hip joint. All right. So he didn't want to translate the knee anteriorly when he did a step down task. We also noticed this throughout the course of his rehab. He just didn't want to bring the knee forward and use that knee too much. So that was a major thing we wanted to focus on in the future from a rehab perspective. So like I said previously, we actually had imaging available. I didn't have access to this imaging initially. So the patient went to the physician and they got some imaging, but they didn't bring it to me, right? So this is not the end of the world. I can start the physical therapy process, but I really wanted to know what the imaging was showing. Okay. We knew there was a meniscus tear. We didn't know what type it was initially. It ended up being a bucket handle tear on the medial side of the joint. What's nice about these types of tears is that depending on where they are, you can usually repair them, right? We'll talk about the clinical reasoning, right, and the decision making a little bit later about why this is relevant. Okay. But when I palpated the joint, so on the medial side, there was some tenderness to palpation. So I'm already thinking like this is probably a medial sided tear if I had to guess. They're going to be a little more common for reparable tears anyway. And that's what the doc is saying is going on right now. So did the patient have any mechanical symptoms? After a meniscus tear, it's pretty common to experience some clicking, some popping, sometimes some locking. And the idea is that that meniscus can get torn, get caught in the joint and create those symptoms, right? So he did have some clicking and popping. He didn't have his knee objectively locking. So objectively locking just means that when you try to straighten or bend, it gets caught or stuck and you can't go any further, right? So he didn't have this initially, all right? And then from a special test perspective, he had pain with end range flexion and extension, which helps to rule in some meniscus pathology. He had a positive McMurray's and a positive bounce home test. Okay. So I like to use the meniscus composite score. I'll give you the link in the show notes to this. This is part of our clinical practice guidelines from 2018, I believe, in JOSPT. So he had a history of catching and locking, right? Or excuse me, not locking, but catching and popping. He had pain with forced hyperextension, pain with maximal passive knee flexion, joint line tenderness, and he also had pain or audible clicking with McMurray's maneuver. So that's a 99% specificity for ruling in meniscus pathology. Plus, we also had the imaging. All signs point to a medial traumatic meniscus tear, right? This ended up being a bucket handle tear with the imaging that we got. So, what is our decision making at this point, right? Like I said, he already went to his physician and they are planning to undergo surgery. So, the physician recommended surgery for this injury. He's currently not able to undergo surgery because of work. So, he's planning on waiting, which the physician was okay with. All right. And he's going to follow up in 2 months to see his progress. All right. So, why would the surgeon recommend surgery? So, A, traumatic reparable tears based on our medical literature should probably be repaired. And the reason being is that we're trying to save the meniscus. We have quite a bit of research to show that if you lose a portion of your meniscus, if you have meniscus tear or you have a meniscectomy, it's going to increase your likelihood of arthritis over the course of time and increase stress on the cartilage. So if you lose the meniscus or parts of the meniscus, you increase stress on the cartilage. The idea is over the course of time, that's going to lead to more arthritis. And if you can repair that, we know there's going to be less eventual osteoarthritis over the course of time. We also have some research to show that if you repair the meniscus sooner than later, so before 3 months after the injury, you're probably going to have a little bit better outcome. Like I said, this individual wasn't able to get the meniscus repaired initially. Not the end of the world. We know that if you repair the meniscus a bit later, you can still have a good outcome, although earlier is probably better. And the last piece is that if you do physical therapy versus getting your meniscus repaired, is that a viable option? We have one study to show that at the 1 year mark, usually the outcomes are about the same. The only problem with a study like this is that we don't know, 5, 10, 15 years down the line, is it better to get the meniscus repaired versus just getting physical therapy, right? So we're not sure at this point. But anyway, we're going to do some physical therapy, see how the patient feels, then we'll make a decision at the follow-up appointment with the physician in a couple months. So, what is the plan of care? What is our treatment for this patient, right? So, initially, our big plan is to restore range of motion. He's a little bit limited still with extension and flexion. Both of those things are going to be a priority. Extension a little bit more important than flexion. So, what do I do as a clinician to restore range of motion? Well, I like to do soft tissue work. So if you're limited with knee flexion, I like to work on the quad a little bit. If we're limited extension, we're going to work a little bit on the gastroc, a little bit more on the hamstring. Okay. We can also do some patellar mobs. I'll also sometimes do some tibiofemoral joint glides to improve that range of motion. And then just doing passive range. Okay. So bending that knee, extending that knee, helping them to get that range of motion back. And then we give them a pretty thorough home program of range of motion to be done frequently over the course of the day. So I like to use frequency over intensity, meaning that I'd rather have the patient do easy range of motion multiple times throughout the course of the day for a lot of repetitions over really jamming that knee into flexion or extension. Now, if someone's not progressing over the course of time, we start incorporating things like low load, long duration stretching, more intensity, that type of thing. But if the patient doesn't need it, I don't push it, right? Next big priority is going to be normalizing the quad contraction, okay? And limiting that quad lag during straight leg raise. And early on in our program, we actually like to use NMES, neuromuscular electrical stim. So we put stim pads on the quads. We stim the quad while we exercise to try to get that quad contraction back, as well as just adding frequent exercise. So I'll tell my patients to do quad sets, knee extensions, 3 up to 5 times per day, 15 to 25 repetitions to just get that quad back on board, right? Next up, we're going to minimize swelling. So minimizing swelling in my mind is going to be managing exercise appropriately, managing the amount of standing that you do throughout the course of the day, and also managing walking, right? Because we want to exercise, we want to get back to standing and walking. We know that all of those things will actually pump some of the swelling out of that area. But if we do too much of that, it's going to increase swelling. So we just have to be smart about how much we do and slowly progress over the course of time, with the idea that when we advance or exercise, we're probably going to increase a little bit of swelling, which is not the end of the world. But we need to make sure we don't swell too much because that can set us back, right? And lastly, we just need to restore that strength as much as possible. We want to restore that loss of hypertrophy. Now, this research is in people that have had meniscus surgery, right? But if you have a meniscus surgery and you don't restore that strength, right, that lack of strength is something that predicts future osteoarthritis. So in my mind, I want to get that strength back as much as possible, right? People always ask me, where do you start with rehab, right? So generally speaking, I want to pick tolerable exercises. So I'm picking exercises that the patient feels are tolerated well. And I want to give them as much as they're capable of, right? This is not a post-op patient. I am not so concerned about re-tearing that meniscus, although obviously I don't want to cause more damage. But what that means is I can give them a lot of exercise and I can give them as much as they're able to tolerate without causing more tissue damage, probably, right? So really, when you see these patients for the first time, you're attempting as best as you can is to meet them where they are in terms of rehabilitation. And oftentimes there's a bit of trial and error that goes on here. So during that initial evaluation, I'll try some squatting, I'll try some lunging, step ups, I'll try a variety of exercises, right? We'll give them the hardest exercises that they can tolerate really well. And I just set that expectation that we may mess up. This might be too much. We'll see how you feel tonight and tomorrow. And if you're super swollen, if you've lost range of motion, right, and you're super painful, we did too much. We got to back off. And they do extremely well and they feel like they could handle more, we just do a little bit more, right? And we just progress a challenge over the course of time. So as we progress, and we're going to go into the specifics of this, we also want a gradual return back to the activities that the patient can't do right now that they want to be able to do. So what's that? Running, strength training, hockey, and work activities. So we have to break down the work responsibilities, what someone has to be able to do at work that they can't do, and come up with a plan about how we do it over the course of time. And we do it in a manner where we do easy stuff and we progress to hard stuff, right? Simple and easy, okay? In terms of physical therapy, I am a less is more type of guy, right? I am an out-of-network provider, meaning that it's a little tougher to get insurance reimbursement working with me. It can be a little bit more expensive for the patient. I tend to work with very motivated patients. So I tend to see patients a little less frequently with the expectation they're going to do a lot of work on their own, right? So for this patient, we started with once a week. For some folks, it's more or less. I tell folks, it depends on how much you want. It depends on your progress. If you're not doing well, we may need to add a little bit more. If you're doing extremely well, we can do a little bit less, right? So that's just a decision I make with the patient, depending on the type of injury they have and also what they want from a physical therapy perspective. And then we can always change that over the course of time, right? And lastly, for our plan of care, we need to modify painful activities for the moment, right? With the idea that if we do too much of basic lifestyle things like squatting, kneeling, walking, it may delay our progress over the course of time. It may make things a bit more painful for the patient. We want them to have a good experience. So initially, we had to decrease the amount of prolonged standing and sitting that we did, just basically breaking things up throughout the course of the day before things got too painful. We had to reduce the amount of prolonged walking as well. I'm a big fan of using a pedometer with my patients just so they have an idea of how many steps are taken throughout the course of the day. And we can break up some of the standing and walking throughout the course of the day and decrease the amount of steps as needed, right? Lastly, the big thing I like to tell my patients is just be nice to the knee, right? Don't do a bunch of things that make it feel really bad, okay? And over the course of time, we just slowly ramp back into the things that used to hurt. So in terms of loading the lower body, that's how we get out of pain, right? So if you look at the research on knee pain in general, but particularly for the meniscus, loading is helpful for these folks, right? So that's going to be our primary way of getting our folks back to pain or back to activity and out of pain over the course of time. And I wrote his entire lower body program, right? And from a strength perspective, 3 times per week, we were doing compound movements, right? I'll tell you what those are in a minute. 2 times per week, we're doing some sort of isolation work with most focus on the quad because that's what was weakest. And the 1 time per week, we're doing blood flow restriction training. It's funny. If you follow me on social media, it kind of looks like all I do is blood flow restriction training. And the reason for that is just because BFR is one of those things that most folks don't have access to at home. And I want to make sure that I maximize what we do in the clinic by doing activities that the patient can't do on their own. So anything the patient can and will do on their own, we have them do on their own, and things they can't do without me, we do in the clinic, which is BFR generally. So what type of strength training do we do? So from a bilateral perspective, we're focusing on the squat and the deadlift. And initially, we're using a force plate as well as mirror biofeedback and video biofeedback just to promote symmetry between left and right. Okay, like I said before, this patient was shifting weight over to their non-painful side. We want to try and normalize that. We also focused on single leg strength. Single leg strength is phenomenal because we're working on restoring any asymmetry that we found in the evaluation. And I like split squats, single-legged squats, step-ups, and single-legged deadlifts. I put a little more emphasis on quad dominant single-leg strengthening simply because that's what was most limited and was limited in the future when we continue to do more strength testing over the course of time. And lastly, a lot of isolation work. I used to poo-poo the idea of isolation work. I thought it was silly and stupid. The only problem is that if all you're doing is functional stuff like lunges and squats, it's pretty easy to compensate over the course of time. We have specific weaknesses. So what's better than isolating those specific weaknesses? So we focus mostly on the quad, but there's also isolation work, as you'll see, for the hamstrings, calves, hip, and core. So what did the home exercise program look like? And it's funny, I'm calling this a home exercise program because that's what we call it in the world of physical therapy, but really it's just a gym program, right? So I wrote a 3-day per week program for my patient to be doing at the gym, okay? So there's a day 1, there's a day 2, and there's a day 3. I asked my patients to have a day's rest in between these sessions. So day 1 would be like a Monday, day 2 is like a Wednesday, day 3 is like a Friday, okay? On day 1, we start off with goblet squats to a ball. We did 3 sets of 8 to 10 repetitions. Initially, we're keeping reps a little bit higher just because he's not tolerating much load. The range was also partial. We went to a ball as opposed to going all the way down. We also utilize dumbbell split squats. We used a long stride length, which reduced a little bit of stress on that knee. And we went through a partial range to an Eric's pad. After that, side bridge abduction. So we're hammering those hips hard. Next exercise was a heel tap with a band behind the knee. We did not use an elevation. It was a very short range of motion just because he's not tolerating a lot of end range flexion quite yet. But we got to start hitting that quad, and some core work afterwards with the band resisted dead bug, right? So like I said, this is all based on trial and error. So the first day in the initial evaluation, we just tried a bunch of movements, and I did my best guess of trying to figure out where that patient was, okay, in terms of what they tolerate. Day 2 was a single-legged leg press. Number 2 exercise, a low box step up, followed by a standing deficit single leg calf raise. Lastly, a machine single leg knee extension to hammer that quad, and then a plank with an overhead reach, a little bit of core at the end there. Day 3, we focus on a kettlebell deadlift. We started with the kettlebell just because the knee wasn't tolerating a lot of load and he was compensating quite a bit. Kettlebell tends to be a little bit elevated in terms of depth as opposed to a straight bar all the way down to the floor, right? We also had some single-legged deadlifts, some side bridges, and some lying hamstring curls with some machine double leg knee extension cherry on the top, okay? And that made up the initial home exercise program, gym program. Now, what is a traditional treatment session at Champion Physical Therapy with Dan Pope for a meniscus tear, right? So I want to give you guys an idea of what we actually do in the clinic, as well as what the home program looks like for these folks, right? So when the person comes in initially, I'm going to ask a bunch of questions about how the knee's feeling today, because that's going to potentially do a few things. So A, change what we do that day in the moment, right? But B, it's going to give us an idea of whether or not we're moving in the right direction. And if we're not, we're going to have to change some things, right? So after we go through that, the next thing I do is just check that range of motion at the knee. So range of motion is going to be one of those things that tells us how we're doing, right? Is there a ton of swelling? Are we getting less range of motion? That's going to be an indication that maybe we're pushing too hard, right? If the range of motion is the same, great. If it's better, awesome. We're moving in the right direction. And the second thing I do is I treat that range of motion deficit. So I take a look at which direction is most limited, and I start working on those ranges. And for me, that's going to be some sort of soft tissue mobilization. So if someone's limited with knee flexion, I'm working on the quad. If they're limited with knee extension, I'm working on the hamstrings and the gastroc, right? I may follow that up with some patellar mobilizations and some tibiofemoral joint glides as well, and some passive range of motion, right? After that, I like to follow that up with some active exercise. So for gaining more knee extension, I might do some terminal knee extensions or some straight leg raises. If someone's limited with flexion, I have them do some self-flexion exercises, all right? After we finish up with the range of motion, we're still dealing with that quad lag as well as the quad contraction deficit. So I love using STIM and MES on that quad to try to gain that back. Early on, we'll do NMES with BFR at the same time, and we'll choose basic and easy exercises that are tolerated well to isolate the areas that are limited. So I'm doing quad sets, I'm doing knee extensions, I'm doing straight leg raises, internal knee extensions with the BFR, with the NMES. Let's get that quad rolling, right? After we do that NMES, we get the quad going. Then we focus on squats, deadlifts, and lunges. And I like to use our force plate, the Vauld force plate, as well as mirror and video biofeedback, just to try to normalize the patient squat, deadlift, and lunge. So how do we progress our treatment over the course of time? Well, basically, we're trying to load the area more and more and go from easier exercises to harder exercises, right? So fairly simple. I start to progress split squats, single-legged squats, step-ups, and single-leg deadlifts more over the course of time. We test the patient. So we test the quads, the hamstrings, and the hips. We see if there's any asymmetries between sides, which over the course of time, everything cleared up besides the quads. So that became our focus. We want to make sure that we get that symmetry back over the course of time. So how do we progress these exercises? Well, we progress the depth. So from a squat and a lunge perspective, we go from an elevated squat, elevated lunge, and we go to a deficit or just a full range of motion over the course of time. Another easy way to increase the challenge of the movement is to add more load. So maybe I'm starting off with a contralateral load. So basically a kettlebell on one side while I'm doing a split squat. And I progress towards holding 2 dumbbells. And eventually I progress towards having a barbell on my back. We can add more anterior knee translation. So if I'm going down in a squat and I don't feel good bringing my knees forward because my knees are painful, then maybe I start with more of a box squat, but over the course of time, I actually want those knees coming forward. So I'll progress towards maybe more of a front squat, and eventually maybe I'll add a slant board or heel lift to really drive that knee forward and increase stress on the knee and the quad, right? And the last thing that's easy to change is just your speed. So if you do a split squat nice and slow on the way up and down, generally it feels pretty good. It's not a ton of stress with the knee joint. And as I start feeling better, I just increase that speed a little bit, right? Now, guys, this is not meant, at least this lecture series today is not meant to be a lecture series on exercise prescription for knee pain. However, if you want to learn more, I go super in depth. I have an entire lecture series. I think it's 4 or 5 videos that are 20 to 30 minutes in length. So very, very in depth on exercise prescription for folks who have knee pain. It's inside of my Fitness Pain Free Insiders program, right? So I'll put a link in the bio if you want to check that out. And it's called How to Dose and Progress Exercises for the Knee. And in that, we have a specific area for the meniscus. So we'll teach you how to do exercise prescription dosage from A to Z there. If you want to check it out, link in the show notes. So how did the plan of care or the gym program progress over the course of time? Okay. So for the squat, we started with a goblet squat. We went through a partial range of motion, and we started with higher repetitions. And over the course of time, we did full range of motion, and we progressed to a barbell variation, so a back squat. We took the repetitions down, right? His split squat with a long stride turned into a regular squat stride, and we did a forward lunge, right, which is a bit more stress on the quad because you have to control the forces of taking a step forward and striking the ground eccentrically with the quadriceps. And it's a little bit more stress on the quad as a result, right? We increased the anterior knee translation on the heel tap, and we also added an elevation. So he was basically doing his heel taps with a slant board, all right, with a little bit of elevation underneath the slant board. So a little extra range of motion to increase the challenge on the quad over the course of time. With the single-legged leg press, we just lowered the repetitions and increased the sets over the course of time. With the box step up, we just had a higher box, which is an easy way to progress over the course of time. The kettlebell deadlift turned into a trap bar deadlift, and we lowered the reps over the course of time. And then for the exercise where we're isolating muscles, we just got stronger. So that was an easy way to progress things. So how did the treatment progress over the course of time in the clinic? Well, things are pretty much the same. Patient comes in, I ask them how things are progressing. Generally speaking, as we progress further into the rehab, things become a bit more routine. We start to be a little smarter about our treatments. We tend not to have as many setbacks, and we don't have to change things quite as much, which is actually pretty nice. It makes things easier for the clinician over the course of time, right? I'm still checking range of motion, and I'm treating what I find. So he gained his extension range of motion back pretty quickly. Phenomenal, right? I don't have to focus on that. So we just focus on regaining what we didn't have, which was knee flexion. And then we just progressed the challenge of the knee flexion exercise over the course of time. The other thing that my patient had to be able to handle was kneeling. So we combined knee flexion with kneeling, which I think was a nice functional way to improve his flexion over the course of time. We started off with quadruped sit-backs to improve knee flexion. And we progressed to a tall knee flexion. So basically kneeling up nice and tall, then sitting your butt to your heels over the course of time. We progressed that to a half knee flexion. So going to a half kneel and sitting your butt to your heel, which is just more pressure into knee flexion. But it's also pretty functional because if you have to lay tile all day long, you're going to be doing a lot of kneeling. The knee has to be able to tolerate that, right? So after we work on that range of motion, we actually started to progress towards more plyometric activity, which as he was progressing all his knee strength, the symmetry was coming back, we start to incorporate some of this, right? So we do a dynamic warm-up after we've done the range of motion, consisting of pogo jumps, sleds, jumps, and running. We finish that up with some squatting, deadlifting, lunging, again with the force plate and mirror biofeedback. And the last thing we do in the session is generally some sort of blood flow restriction. So you'll notice the order changed a little bit. One of the things about blood flow restriction training is that it absolutely destroys your legs, right? So if you start with BFR, you're probably not going to have good quality of movement afterwards, right? So it tends to be more of a finisher when the individual progresses further along into the rehab program. So, how do we progress back to plyometrics once the patient can tolerate it, right? So, I generally start my plyometric progression with some pogo jumps. So, we do pogo jumps. If you don't know what a pogo jump is, imagine standing with your feet together and just jumping up and down nice and easy, right? That's a pogo jump. Over the course of time, we introduce multiple planes, right? So back and forth, front and back with a split stance, feet wide out. So going out wide and coming back together. I also like to do nice slow jogging early on. We do some tall shuffling, some tall karaoke, right? And this is my basic introduction to plyometrics. I usually do this for about 2 weeks. And if the patient is tolerating that really well, we start a return to run program. So I stole this directly from Chris Johnson. I've been using it for years. It works really well. Patients do a 10 to 15 minute run, right? And generally speaking, you're doing this 1 to 2 times a week. Some patients will do it 2 to 3 times a week if they really want to get back to running. That's their major goal. But it's not 15 minutes of running straight, right? So week 1, we start with a 30-minute jog, nice slow jog, and a 30-minute walk. And you repeat this interval until you're done your 10 to 15 minutes. Week 2, you advance the jogging and decrease the walking. So it's now a 40-second jog and then a 20-second walk. Repeat 10, 15 minutes. Week 3, 50-second jog, 10-second walk. Repeat 15 minutes. And week 4, there's 3 by a 5-minute jog and with a 1-minute walk in between. And that's about 15 total minutes of jogging. That's going really well. Then you can just do 15 minutes of jogging. And over the course of time, you can either increase the amount of volume, so 15, 20, 25 minutes of jogging, or you can start to increase the intensity, which usually for me is some sort of interval running program, right? So generally about 2 weeks into this return to run program, if the patient is doing really well, we start to incorporate more change of direction work. And usually the very start of change of direction work for me is going to be a little bit of sled work, where we work in multiple directions, right? So lateral sled drag, lateral shuffle. I also like ladder drills. So one thing about ladder drills is that they are a phenomenal, basic, and easy way to start incorporating some change of direction work. I think you have to be careful though, and this is what I see at a lot of physical therapy clinics, is that ladder drills in their mind are advanced change of direction work. It's not. It's generally relatively easy. Those forces are not huge. So I think it's a good introduction, but you probably have to work towards more challenging change of direction over the course of time, right? Once the patient was tolerating these basic change of direction moves with the sled as well as the ladder, we start progressing towards shuttle work. So I'm doing shuffling, lateral running, backpedaling. We start with shorter distances and we work our way to longer distances. Over the course of time, and we didn't have to do this much with my patient, but just to give you an idea, if your individual is getting back to, let's say, higher level field sports, we probably want to make these change of direction drills more reactive. So reacting to, let's say, a ball, so running towards a ball, reacting towards another athlete, right? Reacting more towards pointing, kind of trying to recreate that game situation. And lastly, you have to layer in endurance with your change of direction drills. So basically having an athlete who not only changes direction well and can do it in a reactive manner, but also does this for multiple repetitions. And we should aim to have the amount of endurance the patient can tolerate be equal to what they're trying to get back to, right? So after the patient is tolerating some change of direction work for a few weeks, I start to pepper in some acceleration drills as well as some top end running, right? Now, depending on the patient and the pathology, you could make the argument that acceleration and top end speed stuff maybe comes before change of direction. I think that comes down to the person and the type of drills you're going to use. But this is what we did for this patient, right? So in terms of working on acceleration, I like to start with fall runs, right? Which may eventually turn into a half kneeling fall run just because it's a little bit more stress on the knee. We start with a lower RPE and we work to a higher RPE. So basically I tell people, let's have you start at a 6 out of 10 intensity, right? Or a 60% of what you feel like your max is. And we work that up over the course of time. We start with low and we progress to high volume. So I usually program, let's say 3 to 4 sets, work my way up to 6 to 8. We start with short distances and work to longer distances. So maybe initially we're only doing 10 meters and then we work our way to, let's say, 20 meters. Be careful with more than 20 meters because at that point, you're not really accelerating anymore, right? You're more doing top end speed. And we also start working at top end speed at the same time. So I usually introduce top end speed running with my acceleration drills. And I like doing this through build up runs, right? Which is basically you pick a distance, let's say 40 meters to start, and you start running slowly and build up, build up, build up until you get to a top end speed, and you maintain that for a little bit and then break down, right? For these, you also start with lower volume, so 3 to 4 sets, and progress that to maybe 6 to 8 sets. You start with a lower intensity and work to a higher intensity. So that's how you can program it for your athletes. And then you start from a shorter distance to a longer distance. So maybe you start with 40 meters and you work your way up to 80 meters. And that's exactly what we did with our patient. He tolerated things extremely well, so he kept on working up over the course of time. The next really important part, especially for this patient, but really for any patient, is communication, right? So the doctor, I have no idea who the doctor was. I've never heard the doctor's name before, so I'm not really sure what's going on within the doctor's mind when the patient met with them, right? On top of that, the patient didn't really fully know what was going on in the doctor's mind either, right? And I don't blame the patient. It's just that the questions that are important from my perspective aren't always the questions that are important from the patient perspective, right? So I didn't really know what was going on in the doctor's head. So before the patient went to their follow-up visit, I gave them a bunch of questions to ask, right? And the questions that I wanted to know was, where is the tear, right? Because that's going to influence whether or not you're actually able to repair it. The other piece was, what type of tear is it? And the last question is, which type of surgery does a doctor want to do, right? Because a meniscus repair will prolong the lifespan of the knee, we hope, right? Whereas a meniscectomy does the opposite. So if the patient is doing extremely well, the last thing in the world I want to do is give them a meniscectomy, although some surgeons may want to do that. Okay. So I wanted to make sure that we protect that patient. Let's make sure the patient knows that when they go back to the doctor, if they recommend that meniscectomy, that may reduce the lifespan of your knee. So we don't want that. Right. So he did go back to the doctor with those questions. Right. And at that point, he was doing great. Right. And the doctor said, hey, no rush on the surgery. Right. You're doing extremely well, but he still believes that repair was the way to go. Right. So at that point, we learned that it was a medial meniscus tear, bucket handle tear, and the doctor wanted to do a repair, although he didn't push it because the patient said, I really can't afford to do surgery right now, which is fine. So the surgeon said, it's probably fine to wait on the surgery. You seem to be doing really well right now. So come back to me when you're ready. I still think the repair is the way to go. Like we said before, if you really want an in-depth understanding of what you should do when your patient has a meniscus tear and they're trying to figure out whether or not they should do surgery, I'll leave a link in the show notes. And I'll also give you a link to click right here if you're watching on YouTube. But the physician thinks that the repair is the best long-term strategy for the individual. I think that we don't have enough research to know if a meniscus repair is going to beat out physical therapy in the long term if the patient is doing really well. So for him, he's doing great. Not really sure what the best plan of action is. The patient actually has decided to go through with the surgery eventually. Who knows if they actually will, depending on how well they do, because at this point, they're tolerating everything. They're back to all the things they want to get back to: work, hockey, their strength training, running. Everything is going really well, minimal to no pain. So it's one of those things where going back to get a surgery, which is going to take a year or more to rehab from, is a tough pill to swallow, right? So this kind of naturally brings us to our discharge planning, right? What is the status of the patient at this point? So one, they have full range of motion. All of their deficits came back. They're symmetrical side to side. The quad is about to where we want it to be, although it's only 85% at the 4-month mark. It's currently getting better from session to session. We're noticing that. And we're also advancing the home exercise program based on that weakness, right? He's back to running. He's back to a full strength program. He's feeling great. Okay. So the last things I do before starting this discharge planning is advance that home exercise program. Let's make sure that we're returning back to all the activities the patient wants to get back to. Throughout the course of this treatment plan, the patient said, hey, I would like to get back to some golf. So we started incorporating a little bit more rotation work with also some advice on how to get back to golf, right? We continue to focus on those weaknesses like the quad, and our home exercise program just started looking like a fitness program that was catered towards his fitness goals, right? The entirety of physical therapy was about 3 months, right? And I'm actually still seeing this patient here or there. So what we do generally is that as the patient's doing really well, we start to decrease the frequency of visits. So I start seeing this patient every other week and then maybe once a month, right? And they just kind of ride off into the sunset over the course of time, right? So I make sure before I get rid of patients that they make sure that they're meeting their goals, right? And here's the other thing. I'm an out of network provider. If this person wanted to stay for the rest of their life, right, and keep on working towards whatever goals they have, they certainly can. But I leave that up to the patient. They make the decision, right? If they want to continue working with me, great. If they feel like they're fine being on their own, I let them do that, right? But that's the difference between in network and out of network. The insurance company is not dictating what I'm able to do. It's based on what the patient wants, right? The value they perceive they're getting from me. And I can tell them, if I feel they need it, I give them my advice or my opinion, and they can make that decision on their own, right? So that's a really cool aspect of being out of network. And that's how I tend to end up doing my discharge programming over the course of time. So if you guys want to check out the references, I'll put that in the show notes. I'd love to hear your thoughts on some of these studies. And if you want to see some of the specific research and have me go through it as it pertains to whether or not to have a meniscus surgery, check out my last podcast. I'll put that in the show notes. Lastly, thank you so much for your support. Thank you for watching this video. If you're watching on YouTube, please give me a thumbs up. I'd love to hear your comments on how I do my rehabilitation for meniscus tears, right? Please subscribe to the channel if you haven't already. If you're watching this via podcast, please leave me a positive rating and review. That helps the algorithm a ton, helps me grow over the course of time. And if you want to go that extra step and support me further, sign up for Fitness Pain Free Insiders. I'll put the link in the show notes. You can just go to fitnesspainfree.com, click on the Insiders online library and get started. In that Insiders, I have the exercise prescription lecture for knee pain, specifically for the meniscus. So check that out. Thank you very much, guys, and I'll see you on the next one.